Hello, everyone. My name is Parul, and I'm pleased to welcome you to today's MHS webinar entitled The Role of Performance Validity Testing in Child and Adolescents Diagnostic Assessment, presented by Dr. Cecil R. Reynolds. This webinar is part of MHS webinar series Unmasking ADHD Practical Strategies to Empower Youth and Adults. We are thrilled to have you all here with us today and would like to begin by telling you a bit about MHS Clinical and Education Divisions. MHS Clinical specializes in aiding the identification and treatment of psychological disorders for improved patient outcomes at all stages of life. MHS Education specializes in providing the expertise and resources required to help children and adolescents reach their full potential in and beyond the classroom. With our advanced suite of tools, team of experts, and robust data sets, we help clients provide comprehensive evaluations and uncover powerful insights. Now, without further ado, it's my great pleasure to introduce you to our presenter today. Dr. Reynolds earned his doctoral degree from the University of Georgia with a major in school psychology and minors in statistics and clinical neuropsychology. He has authored over 300 scholarly publications and 50 books, including The Energetic Brain and the Handbook of Clinical Child Neuropsychology. Dr. Reynolds has developed over 50 tests and holds 3 US patents. Dr. Reynolds maintained a clinical practice for 25 years, specializing in trauma and traumatic brain injury, and served as chief of neuropsychology at Sandstone Psychiatric Hospital before retiring in 2003 to focus on forensic work and writing. He has also served as editor-in-chief for several leading journals and currently edits the Journal of Pediatric Neuropsychology. He is a diplomate in clinical and pediatric neuropsychology and a former president of several professional boards. Over his career, he has received numerous honors, including APA Division 16 Senior Scientist Awards, as well as the President's Gold Medal from National Academy of Neuropsychology. We are so glad to have you here with us today, Dr. Reynolds. As we begin our presentation, I would again like to quickly remind everyone that there will be a survey sent to you in order to satisfy CE credit requirements. If you do not receive this email before the end of the session, please send us an email at marketing@mhs.com so we can send it to you. Now let's start the webinar. I will hand it over to you, Dr. Reynolds, now.
Thank you, Parul. I appreciate the introduction. And welcome, everybody. Thank you for being here today. I know your time is quite valuable, and I appreciate your willingness to share some of it with me today. And hopefully you will find at least some of what I have to say valuable, if not, who knows, even interesting. So we're going to be talking today about the role of performance validity testing in child and adolescent diagnostic assessment. We're going to go through that in some detail. And one of the things we'll be talking about is an instrument that I've developed with some colleagues. And while I'll be doing the training on that, I do want to acknowledge Bob McCaffrey, Julie Lynch, and Robert Lurk for their contributions to this as well. And as we talk about that instrument, which is the Pediatric Performance Validity Test Suite, just know that I receive royalties from its sales. And while I view my comments and opinions as expressed to be accurate, you should always judge the facts and materials for yourself and make an independent decision about your choice of diagnostic and related techniques and how it fits into your practice with your patients and your examinees. So what we hope to accomplish today is a brief overview of literature on pediatric performance validity assessment with an emphasis on the need for evaluating effort in both clinical and school settings. And this issue of performance validity testing is going to be important whenever you use tests of maximum performance. And I'll define those in detail for you in just a few minutes. But that would include things like intelligence, academic achievement, any kind of neuropsychological testing or psychoeducational testing. And then, as I mentioned, we'll talk specifically about the most recent and the most comprehensive performance validity test available for children and youth. So, unless you've kind of been under a rock for about the last 5 years, you're probably familiar with the fact that there have been huge scandals related to college admissions cheating and kids getting psychologists and other people to give them specific diagnoses that allow them to be in a special admissions track for college or to get special accommodations for their entrance exams or for other purposes related to that. And some of that involves collusion with examiners, but some of it is simply a matter of having kids fake their performance. And one of the things that we've seen is that it was much more widespread than we thought. We all knew that this kind of thing went on, at least something along these lines. If you were involved in assessing adolescents, you knew that a certain percentage of them would fake things like ADHD, would fake specific symptoms like attention problems, might fake stress where they couldn't work under speed, might do things like that that weren't legitimate for them, although they were legitimate for the majority of kids that we saw who expressed these problems. And the issue for us is figuring out which ones really do need these accommodations or special admissions tracks and which ones don't. And that became a problem. And it became a public problem as the media began to really flock to this story and really publicize it, primarily because some Hollywood celebrities got involved. So once that happened, it really became popular in the media. And it's still around. And in fact, some of these celebrities even went to prison. So our solution for that is to move to performance validity testing. And a performance validity test is a measure whether the individual you're testing is giving their optimal performance, that is, their best effort, on tests traditionally characterized as a maximum performance test, so that we can rely upon our common interpretations. But these interpretations rely upon the examinee doing their best. Did they really try? And that's critical to our ability to be able to interpret our tests. Some other lingo around this that you'll encounter as you read this literature and that you may hear me use today are terms like effort testing, which I'll talk about a lot, response bias testing, symptom validity testing, and performance validity testing. And at one time in the past, all of these terms were used synonymously. We no longer do that. We differentiate among some of these. Symptom validity testing, for example, is now used to refer to the veracity of an examinee's subjective or self-report complaints if they tell us they have certain problems. And so we use a different form of assessment to determine if we're getting symptom validity. And we call those symptom validity tests, strangely enough. Performance validity, which is also effort testing, refers to the accuracy of the examinee's cognitive scores as an indication of their actual cognitive, neuropsychological, or educational status. And as I said, we refer to this as effort testing because that's the key issue on maximum performance tests. Did they do their best? For many years, clinicians, myself included, by the way, believed that children really didn't lie or malinger or engage in dissimulation as adults might do. Or if they did, and we knew a very small number did, it was easy to detect. Oh, we'll know. I have so much experience with kids. Kid isn't giving me good effort or is trying to deceive me. I'll know. Turns out the research says they were wrong, including me. We're not as good at this as we think. So, are children capable of deception even? How young? Children begin to start deceiving others as early as about age 2.5. And this early lie telling is usually kind of self-serving. No, I didn't eat that cookie, even though we can see the crumbs on their face. But it's a consistent pattern across cultures and is a normal aspect of development. Children begin to do this because they haven't learned the rules yet. They haven't learned that they shouldn't engage in that kind of behavior, and it's part of normal development. But how well can they conceal it? It turns out that even young children, even below the age of 8, show good what we call nonverbal leakage control. They show positive nonverbal behaviors. And a lot of people think they can look at a person's nonverbal behavior and detect deception. Turns out you really can't. They make good eye contact, they have relaxed facial expressions, and use a positive tone of voice. In fact, sometimes they show more positive nonverbal behaviors than kids who are anxious but telling the truth. But they tend to show poor semantic leakage control below the age of 8. They make statements that contradict themselves. But after about age 8, most kids, not all, but most kids, are able to conceal their deception with plausible responses to follow up questions. And it's related to cognitive development. There's a positive correlation between lie telling and executive function. As we develop better inhibitory control, better working memory, and better planning skills, we get better at concealing deception. And children with better executive skills and good theory of mind are able to maintain their line, and they're less apt to make contradictory statements. So they can come in and engage in inaccurate symptom presentation, but also give us less than a best effort and conceal it with their nonverbal behavior. But is it really a problem in pediatric evaluations? If we look at some of the research, and I'm not going to cover it all today simply because of time. In fact, I will hit some of the slides I have for you today very, very quickly, but please don't be concerned. I wanted that content to be available to you in the handout, even though we will not cover every single piece of it in the lecture portion today, but you will get all of this in the handout. But if we go and look at a 2007 study, for example, and we look at failure rates on a couple of popular assessments of effort that were developed for adults, and those are then applied to children in Social Security disability exams, where they might be looking for SSI because of severe ADHD, ASD, or other specific problems. And you can see that the failure rates on the effort tests are quite high, anywhere from about 23% up to as high as 37%. And depending upon the measure, that will vary some. But those are big numbers. If we look at rates of suboptimal effort detected in a clinical sample, children with a mild TBI, we see again about a 12 to 19% base rate of failure on various effort tests. We see it in another sample where we have a 14% base rate of suboptimal performance in a clinical sample, and this was a mixed sample of psychiatric, neurological, and neurodevelopmental conditions, including things like ADHD. And after the exam, the children who failed the effort testing were interviewed. And at that point, when they were confronted with these failures, they acknowledged that they really weren't doing their best. There are a number of other published reports. A number of them, interestingly, center around malingered ADHD. This is particularly a problem in juvenile justice settings, and there's been a lot of publication about this, where juveniles in this setting will feign ADHD symptoms in order to obtain medication. And they get knowledge of these symptoms from group therapy sessions with other juveniles who are in detention who legitimately do have ADHD, but they also get it off the internet. And there are a number of these. We also see juveniles who are before the court who will give less than best effort in order to appear to have various cognitive impairments or brain injury or other impairments that might lead to a lesser sentencing. So we see this in a lot of different arenas. We also see published work indicating that parents are often complicit in encouraging and coaching their children to give less than a best effort in order to obtain a specific diagnosis for a specific outcome that the parent is seeking with the child. So if you go to this literature, you will actually find a great deal of research on this going back for decades. So it's not a new problem. It's not a new problem. It's just over the last 10 or so years, a problem of which we have a lot more recognition and a lot more insight, and one that we've made tremendous progress in how to solve. So again, lots and lots of specific problems published in the literature, and it shows how pervasive this can be. Well, how prevalent is it in LD and ADHD evaluations? We see it early in college careers, 18-year-olds, specifically undergoing evaluations for various accommodations at college. And the failure rates range anywhere from 15% to almost 50%. And students seeking accommodations for ADHD lead the pack in failing effort tests. So it's particularly a problem in this population. We also see that it's a real problem in Social Security disability exams and in mild traumatic brain injury litigation. We note here that the failure rates have been estimated to be between 48 and 60% among populations seeking Social Security disability benefits. And ADHD is one of those populations. Among mild TBI children and adolescents, 12 to 20% in meta-analyses looking across lots of studies. So it's really essential as part of our practice to determine whether or not our test data can be relied upon or interpreted as valid representations of the child or youth's real ability and real performance. We need best effort from our examinees if we're going to make diagnostic inferences that are accurate. So to be confident that the results of our comprehensive evaluation are valid, we have to have a measure of whether the individual under assessment is giving their optimal performance. Ralph Raitan, and I hope that name is familiar to you, um, he was really the guru and the godfather of neuropsychological assessment and practice in the United States, at least. And for more than 40 years, he really pounded a pulpit that you cannot draw inferences about brain status or brain behavior relationships unless you elicit maximum performance from the examinee. And this is especially critical in the diagnosis of neurodevelopmental disorders. Anything that's brain related, you have to be sure you got their best effort. So, just to be clear about maximum performance tests versus typical, maximum performance tests include things like tests of intelligence, aptitude, achievement, memory, any neuropsychological test, any test of ability or skill where we are asking, how well can you perform this activity? That's where effort testing is essential. For typical performance tests, which are things like measures of personality and behavior, most behavior rating scales, assessment of attitudes, other variables where we're asking, how do you typically behave? How do you typically think about things? Or how do you typically perform? That is an area where we use a different set of tests and requires a different mindset. That's where symptom validity testing comes into play. But just remember that in the absence of best effort, accurate inferences cannot be drawn about brain behavior relationships, about intelligence, about academic levels, or other skills like the ability to pay attention, not the willingness, but the ability to pay attention, the ability to engage in things like sequencing, to access and use working memory as well as you can. All of those things are influenced by effort. Dissimulation is a word that you will hear, and you heard me use already, that simply means an intentional presentation by someone that's inconsistent with or dissimilar to their actual or true clinical state. And children are clearly able to follow instructions to engage in dissimulation when we give them properly worded instructions. We were able to get children to attempt to engage in dissimulation as part of validity studies of our performance validity test, and so have others. And as I mentioned, there are published studies where parents have been successful in getting their children to engage in dissimulation as well. So, how do effort tests work? If we're going to be using them, um, they provide stimulus materials or tasks that appear to be difficult and to require effort and attention to answer correctly. The perception of difficulty is often reinforced by the directions that we give. In fact, though, the tasks are relatively easy, and few examinees who exert best effort and pay attention will miss more than a very small number of items, and it's not unusual for them to get 100% of the items correct. We frequently use multiple choice tasks because of the totally objective scoring, and we can also detect chance levels of responding through an easy calculation, and that can reinforce decision making about suboptimal performance. So, why do we need tests to do this? Well, just very quickly, as it turns out, we're just not good at it, except in really extreme cases. We need actuarial, empirical, that is, objective help. And you will find in the literature, and I'm not going to um, to spend a lot of time on this. Studies going back, starting really solid studies around 1978 and progressing from there until just recently with newer studies, where neuropsychologists and psychologists have been asked to determine from reviews of case data who's faking and who isn't. And it turns out that most of us perform at a chance level. In this first seminal study by Bob Heaton and his colleagues, the best performing clinician was only 20% better than flipping a coin at figuring this out. We see newer studies reporting the same thing. Basically, we are about as good in most instances as flipping a coin. And it turns out that in specific studies of detecting deception in children, a meta-analysis of some 45 studies found that adults in general are no better than chance. So we have good evidence that we need help. And turns out performance validity testing is now routine in forensic evaluations and has been for quite some time. If you go to court with an examination that includes maximum performance testing and you didn't do performance validity testing, you're going to get toasted on the witness stand. And that's as it should be. You need data. And we now know that PVT should be included in all clinical exams of children and youth. This has been reinforced in position papers and white papers on practice guidelines from both the National Academy of Neuropsychology and the American Academy of Clinical Neuropsychology. And it is important to understand, and I think that you do, that diagnosis and classification decisions in schools and clinics are equally, if not more important than most forensic assessments, and require performance validity testing if we're to interpret our performance data accurately and objectively. You make life-changing decisions about these children and youth, and you want to be sure that your data are solid and that you can rely upon it as representing best effort. Our professional organizations have emphasized this now for a very long time and have recently gone out of their way to emphasize in updates to the original position paper on this that these requirements for the standard of care now include exams of all children and youth. So in 2021, the most recent update to the professional standards say that there is a near universal acceptance of the need to use standalone performance validity measures and embedded validity indicators both in clinical and forensic exams. And they go on to tell us that this literature now says that this should routinely be included in evaluation of school-age children and adolescents. So what we're looking for when we do performance validity testing is to detect suboptimal performance if it's there, which is instances of the examinee not doing their best. So that's what we're measuring. Did we get maximum performance? Did they comply with the test demand, do the best that you can, work as quickly as you can, or our encouragement for them to do that? Did they respond to us? So are these an accurate representation of ability, which is what we're trying to find out. So when should you do it? Anytime you give an exam that includes any maximum performance test. But remember that children and youth give less than optimal effort for a lot of reasons. They're not always malingering or faking or engaging in dissimulation. Sometimes um, they're just bored, um, and maybe your level of rapport is not as good as you thought, and we need to re-engage. Or maybe we're bored in the exam. We've done this test so many times that we're a little bit routinized with it, and we're not as encouraging or as engaged as we need to be. So whatever the reason, we need to re-engage kids. The literature says that these performance validity tests should also be interspersed throughout an exam. Don't give them in clumps, or just give one at the beginning and move on. And don't rely on just one, because that would assume effort is constant across the exam. If you have tests that have embedded effort measures, the current advice is to use at least 2 freestanding performance validity tests. If the tests you're using do not include any embedded measures of effort, then use 3. So it turns out that the most recent survey data we have indicate that the average neuropsychologist, at least, is using about 5 if you add together the freestanding and the embedded in the context of a truly comprehensive exam. But remember, it doesn't mean malingering. Malingering requires a much larger investigation, and malingering is intentional. Suboptimal performance may or may not be intentional. It is only one potential explanation. So failing a PVT doesn't automatically indicate malingering, but it should prompt you to investigate why you weren't getting best effort. And again, kids can give you less than best effort for a great deal of reasons. And you need to consider all of this. So use multiple PVTs, scatter them throughout the exam, and consider what's happening when you get a failure. And when you interpret it at the end, be sure that you understand the base rates for failure of PVTs as a function of clinical groups. And I'll comment on that again in a few minutes. So there is clear evidence now, as I answer this question for you, that failing PVTs is associated with lowered scores on maximum performance tests. There are a lot of studies of this. I'm not going to bore you with going through all of them in detail, but with children, as we find with adults, children and youth who fail performance validity tests routinely earn lower scores on other maximum performance tests given within the context of the battery. So we see this routinely. This happens to be my favorite study because they have such a large sample. It was consecutive children seen for a variety of neurodevelopmental disorders, which includes ADHD populations, and failure on each PVT was found to be associated with a significant and widespread suppression of scores across the neuropsychological battery. So when we had failed PVTs, we may not know why they failed, which is not what the score tells us. It only tells us that in the context of a failed PVT, the obtained test scores cannot be used accurately to determine the presence of cognitive deficits, a neurodevelopmental diagnosis, or to make appropriate treatment or service recommendations. And we need objective evidence to be able to say, yes, I can interpret these tests as I typically do in the context of an exam, or no, I can't. Another reason that I've discovered in my own use of PVTs that I think is actually very valuable, in fact, it's my favorite reason for using them, is it makes me a better examiner. And there are times, as I said earlier, that we get suboptimal effort because of our behavior. And I don't think any of us are perfect always with all our examinees. I know that I'm not. And it alerts me to my level of attention to the examinee if they fail. It alerts me to my level of rapport with them. It tells me maybe I'm not as engaged with this examinee as I need to be sure I get their best effort. So it helps me stay on task and keeps me engaged when I see a performance validity test failure. So I think these tests make me better at my job. And again, that's become my favorite reason for including them, is to keep me at a heightened level of awareness of my examinee and what I'm doing. So let's look at some pediatric performance validity tests that have been developed for children and adolescents. There are really only two out there available now that are specific to children and adolescents. One is the Pediatric Performance Validity Test Suite, of which you'll see my name on as an author, and the other is the Memory Validity Profile. In practice, what has happened because of the absence of such measures designed for children is that people have adopted and adapted adult tests. I've never liked that with children. Children are developmentally too different. There are some measures, though, that have embedded performance validity tests. The CHAMP, for example, has some built-in validity indicators. The CVLT children's version has two embedded measures, and the Test of Memory and Learning, second edition, has a built-in effort measure. So there are some for children that have embedded measures. But typically, for freestanding, people have adapted adult measures. It's better to have something designed specifically for use with children and adolescents. And that's why we designed the Pediatric Performance Validity Test Suite. It consists of 5 different measures, which can be used independently of each other or in any combination of 1 to 5 that you need to use in your particular exam. It's designed and normed and has validity data and base rate data from ages 5 all the way to 18. So I'll take you through these here in a few minutes. It provides an efficient, objective approach to assessing performance validity with children and adolescents. So 5 individual tests covering both verbal and visual domains with child-friendly stimuli. They're designed to engage children and youth and are not an extension of an adult test. It is completely digital. You can use this on any iOS or Windows touchscreen or Windows desktop with a mouse. Although on a desktop, if you're using a mouse with no touchscreen, one subtest, Find the Animal, is not available. And it's available in English and Spanish. Each of the 5 tests takes between 3 and 5 minutes. So it's not terribly time consuming. So you can sprinkle them in throughout your exam. It has a flexible administration. The number and order of the test is at your discretion. And that's on purpose. We want you to disperse them at various points throughout the evaluation. We have age-specific cut scores and immediate access to test score outcome. That is, did they pass or fail? As soon as they complete the specific test, you simply tap in the completion code and you get an immediate result. You can also generate a computer score report that includes base rate data for the general population and 9 different clinical groups. And no one else provides anything near the level of base rate data that we have. And this allows you to make an objective database decision about whether or not the examinee's performance represents their true level of ability or skill. Did you get appropriate effort? Or did you get suboptimal effort? If you get suboptimal effort, the common interpretations of scores as reflecting the constructs you intended to assess are not valid and you can't rely on them. So what do? Well, you work with the examinee. When they fail that PVT, you work with them to assure that you get best effort from that point forward. So it really improves the exam. Who should be using these? If you're using the kinds of tests that are used in comprehensive psychological exams, you're going to be qualified. So if you're credentialed in your jurisdiction to use psychological and psychoeducational tests, then you are appropriately credentialed to use performance validity tests. We recommend that you be familiar with things like the standards for educational and psychological testing, that you have training in, obviously, in assessment, testing, all of those things. But it's nothing special to be able to use this other than learning the test. So we wanted to have tests that were engaging specifically for children and youth. We wanted to develop tests that are culturally neutral and know that there is no such thing as a completely culturally neutral test. Tests always have a context. And I don't care what anybody says or what anybody claims. There is no such thing as a measure that is completely culturally neutral. But we worked very hard to approximate that goal. And we had lots of reviewers from different cultures, different countries around the world, and we made modifications and worked with items and followed that process throughout. We wanted to cover multiple domains that were relevant to cognitive evaluations that are comprehensive and plausible to the children as measures of cognitive function. And we wanted to be sure all of this could be accomplished in a digital format that was compatible with lots of platforms and lots of devices. This needs fast, easy, objective, and effective in terms of its sensitivity and specificity. So let's take a look at the Pediatric Performance Validity Test Suite and see what these tests look like. So if you'll follow along with me, the first one we call Find the Animal. This looks at visual scanning and classification. And what you have up here are the first 3 screens that the child would see once you initiate this subtest. On the first screen on your far left, you tell the child you will see 7 circles around a home button like this. Show that to them. Go to the next screen and say, press and hold the home button. When you do that, pictures will appear in the circles. So all those empty circles then populate. On the next screen, only one of the pictures is of an animal. Tap the animal as fast as you can. Then press and hold the home button while you watch for the next animal to appear. So what happens is when the child lifts their finger from the home button and taps the animal, it scores whether they tapped an animal or something else. The circles all go blank. When they put their finger back on the home button, at a random time period between 0 and 2 seconds, all the circles repopulate. And then the child taps the next animal. And we emphasize do it as fast as you can to encourage the difficulty level of this. So it is a simple task, but we encourage them to go as fast as they can. The next task is called matching, which is a purely visual recognition task. On this second subtest, well, it's not really a subtest, I'm sorry, I misspoke. These are independent tests that are used independently. On the first screen that they show for this, you will see a picture by itself like this. Look at this picture very carefully and remember it. On the next screen, then you will see 3 pictures like this. We tap next, then tap the picture that you saw before as fast as you can. So it's a simple memory task, visual recognition. Do they remember the one they saw? Shape learning, which is much more complex abstract shapes. The first screen for this third task, you will see a picture by itself like this. And you can see that that's a very complex drawing, and that's on purpose. We want it to give the appearance of being difficult. On the next screen, then you will see 2 pictures like this. Tap the picture that you saw before as fast as you can. So we always want them to think that their speed of performance matters. In reality, it doesn't. We're only scoring correct and incorrect. We actually looked at that during the standardization, and we continue to collect speed data. And it turns out that speed didn't differentiate among clinical groups or among kids who were not giving best effort, who were actual simulators, and those who were not. But what differentiates really well is correct and incorrect. So tap the picture you saw before as fast as you can, but the instruction to work quickly enhances the illusion of difficulty. The next is called silhouettes. So this fourth task is another visual organization task. You will see a picture at the top of the screen and 3 pictures at the bottom of the screen like this. Next screen, the picture at the top of the screen has pieces missing. Now tap the picture at the bottom of the screen that is the completed version of the one at the top. Tap your answer as fast as you can. So this is in essence a relatively easy Gestalt closure task, but one that in fact in harder versions appears on some cognitive tests. So again, tap your answer as fast as you can. So we help reinforce the illusion of difficulty. Next, we have a verbal task, story questions. All the other tasks go down to age 5. Story questions starts at age 7. It turns out we could not find a way to make this easy enough for children who were 5 and 6, especially those with any kind of actual disability. The child or adolescent does not see the screens. This is entirely done by the examiner. So do not share the screen with the examinee. You start out by saying, I'm going to read you 2 sentences. Listen carefully because I'll ask you questions about them. Any questions? Let's practice. Then we have a couple of short stories, also known as sentences. Sally likes to read. Her favorite stories are about aliens from another planet. What does Sally like to do? Watch television or read? And hopefully they say read. Correct? What are Sally's favorite stories about? Aliens from another planet or superhero? So we get 2 multiple choice questions. out of each of these. For older and adolescents, ages 12 to 18, the format is the same. We simply have significantly longer stories. So it was the day of the big play, and Julian was starting to get nervous about performing on stage. And we go on and read the complete story. And then we ask questions. What day was it? The day of the music recital or the day of the big play? Hmm? What was Julian nervous about? Performing on stage or taking a math test? So story questions gives us a verbal task. All of this, as I said, is on a digital platform. There is an internet connection only required for a couple of things. Downloading the application, you must have an internet connection. And the very, very first time you log into the app on a device, you need a digital connection. After that, you don't need a digital connection for anything except generating a detailed score report. You can do fully offline assessments. You can set up a new client. You can administer the test, each of the 5 tests, and immediately get a pass fail without an internet connection. You only need the internet connection at that point when you're ready to generate the detailed score report. So you'll be able to use this in settings where you may be denied access to the internet. Remote administration is also available. 4 of the 5 PVTs here can be done by remote administration. The only one that cannot is find the animal. We do have some special instructions. There's a link to it here. So use those detailed guidelines if you're going to be using it remotely. It has a good normative sample. It's demographically representative of the U.S. population. But in fact, norms are not what are critical to performance validity testing interpretation. It's really the performance of the clinical samples and the base rate data and how accurate are our cut scores. And we have 9 clinical samples. We also have a simulation sample that was used to help us set cut scores along with the clinical samples. We had kids who were clearly instructed to fake their performance and to look like they were particular difficulties. Turns out we're really good at detecting that. We set cut scores to maintain specificity at 90 to 95% and be sure that we had adequate sensitivity. And these are all age adjusted. And it was in that process that we identified that story questions simply wasn't developmentally appropriate for ages 5 and 6. It simply over-identifies. We have very good internal consistency reliability, but more important than internal consistency reliability on a test where you're trying to classify someone into one of 2 categories is their agreement. It's the agreement on pass fail. And if you look at the test retest classification agreement column, you'll see that it's very, very high. It's 100% for um, uh, uh, for 3 of these. For story questions, it's a little variable depending on age. And we were at 93% with silhouettes. So the agreement over time 1 and time 2 is very high. You can look at the pass fail rates that we have, and you see that in the general population, the pass rate is very, very high. It is also very high, just a slight bit lower in clinical samples. And in the simulation sample, look at the failure rates. That means we detected the simulation sample at this level. So we were 95% accurate in detecting, for example, failure on Find the Animal, and 96% with the matching task, and so forth. So this worked really well. And you can see this by age. We have all the data for this um, for all different age groups on all 5 tasks. So we have a lot of base rate data for you, not for just the general population, but for the clinical population. And keep in mind that sensitivity and specificity are critical. And so we worked very hard to set our cut scores to maximize sensitivity and specificity values. And high specificity is especially critical. And prior to the PdPVTS, there was not much data in children and youth. And now we have a lot. So for other tasks, the verdict is out on children and youth, but we provide you with extensive base rate data with the PdPVTs. And you can see this in the manual, but we also reproduce this in the clinical reports. And I'm about to show you those so you will have a better understanding of how we report this. So as you can see here, the pass rates, for example, in legitimate ADHD groups is at 94.5% at the lowest. And all other kids who are correctly and legitimately diagnosed with ADHD pass this at very, very high rates. So if you're assessing a child for ADHD and they fail the performance validity test, the odds are extremely high you're not getting adequate effort. And again, we have these kinds of data for 9 different clinical groups. We also give you the base rates for every possible combination of these, and you'll see that in the reports. The only clinical group where we have concerns are with intellectual disability. And this has been a problem for decades in forensic and other settings with intellectual disability groups. No one has been able to come up with a performance validity test that is as accurate in the diagnosis of intellectual disability as with other neurodevelopmental disorders or other groups like TBI, learning disability, or others. The intellectual disability group remains less accurate on all performance validity tests at all ages, including with adults. So the computer score report gives us a lot of data. And rather than just talk about that a lot, I'm going to show you. So I know that's too small for you to see, but it's a quick look. It gives you everything you need to know. So let's see an example of some of those. Here we have a 14-year-old female with a history of ADHD and oppositional behavior. During her comprehensive neuropsychological exam, she was given all 5 of the PdPVTs. She failed 3 of those 5. So what does that mean? Well, it probably means we were not getting adequate effort from her throughout the exam. But how does it compare? Let's look at the base rates for this. So this would be in the computer generated report. So she took all 5 and she failed 3. So on the left-hand side is the base rate for failing each of these tests individually. But more importantly, on the right-hand column are the base rates for failing a combination of tests. So she took all 5, she failed 3. So if we look at the column where 3 represents the number of failures and we read down, no one in our ADHD samples failed 3 out of 5. That is off the charts unusual. So we are very, very safe concluding we did not get maximal effort from this young woman in our assessment of her abilities. So those are the kinds of base rate data that we can get out of this. Here's another 12-year-old male with a sports related concussion. He passed all five. We can have a lot of confidence. You look at the fail rates of 0, which is what he failed, and you see that in the general population, um, it, 6.5% would have failed 1. And here we have a concussive injury. Um, so we have very, very strong confidence that this young man was giving his best effort, and we can rely upon those test scores. Here we have another one with ADHD, a 13-year-old young woman who had both ADHD and learning disability, was only given 4 and passed all 4. So you can see if they were given less than 5, she wasn't given silhouettes, so we don't see data for silhouettes in her base rate table that accompanies her report. Here we see the base rate data, and we can see again that we can have great confidence. Isaac, a young man in litigation for a mild traumatic brain injury, only was administered 2, which is the recommendation for the minimum number that you give, failed them both. So what does the base rate data look like? Well, we only get base rate data now in the report for the 2 that were given, and we see that it's very, very unusual to find failure on 2 out of 2 across all populations, including mild TBI, severe TBI, and in the general population. Even in the mild TBI sample, only 2% failed 2 out of 2. So we have very strong confidence not getting best effort. So we give you a great deal of detail in what is a very short and to the point computerized report. And you have a lot of data to work with to base your conclusions on. The system requirements are pretty minimal. You will be able to do this on most any device that is less than about 20 years old. But be sure you check the system requirements first. So once you've done with the testing, you simply punch in your password. You get immediate pass fail. Save the session. You have up to 30 days to administer additional PVTs to the same individual. Once you, though, type in the code to end the session, you cannot give additional PdPVTs as part of this assessment with this examinee. You would need to open a new assessment session and get new data. So that's what we've been doing. That's what we're encouraging you to do, to work with this, to take a hard look at using PVTs in your practice, evaluating neurodevelopmental disorders in particular. We hope you'll like the PEDS PVTs. If not, find one you like. It's important to include this. And at that point, I'll pass over and see what kind of questions you have for me and how I can help you with your understanding of both how we use this and the need for it. Thank you again for being with me today.
I will now go to questions. Welcome, Dr. Cecil. We have a couple of questions for you today.
Great, great. I hope everyone enjoyed the presentation, and let's see where I can help.
Okay, yes, let's start the question. So the first question I have is, If a child's performance on a cognitive test falls within the average or above average range, is it still necessary to conduct performance validity testing?
It is if you're using a test of maximum performance, because just because a child performed in the average range doesn't mean that that was the best that they could do, even if they're above average. So if you're going to be looking at, for example, any kind of comparisons or profiles of their cognitive skills to see if they might have specific deficits anywhere or might have other specific strengths, um, then it's important to ensure that, in fact, you did get maximum effort. Um, if a child is referred, there's generally a reason why. And if we're going to understand how to answer the referral question, even children with above average performance on intelligence tests, for example, have issues. They get referred sometimes. And so we still need to assure ourselves and be sure that we had sufficient rapport and were encouraging enough in the exam that we did get their maximum performance. So it remains important to know if we did that. It also sends us a message if we're using uh, uh, performance validity tests that we need to be sure we're engaged. So there's another reason to give them. And I talked about that a little bit in the presentation, that it makes us better examiners. So that's actually my favorite reason for using PDTs with kids, is that it makes me a better examiner. It ensures that I maintain rapport, that I stay engaged, and if for some reason I lose that, that I re-engage with that child. So yes, it remains important in any exam where you are including maximum performance tests.
Yes, that's really helpful. Um, the second question I have is it is sometimes suggested that it is not unreasonable to use working memory items from cognitive testing as a proxy for an embedded PVT. Would you agree to this?
Well, how do you know, since working memory tests are designed in such a way that children fail half the items, that you're not getting their best effort? Norm reference tests that are designed as maximum performance tests are specifically designed so that the average child fails half the items. So how, if you're attempting to measure their working memory, can you discern level of effort from that? Now, if you were, for some reason, using a working memory test, maybe that's multiple choice and they perform below chance, sure, you could use that as an embedded measure. Um, but otherwise, I don't know how you can get to a proper interpretation of a norm referenced working memory test as a measure of effort. Because there are clearly are children with impairments in working memory. And how you discern which is which, I don't know. When you have a norm reference test that is purposely designed so that the individual taking the test, the average individual taking the test at each age level, is supposed to fail half of the items.
Absolutely. The next question is the information related to the difficulty of recognizing dissimulation is compelling. That was a comment. However, the question is to what extent pediatric or adult clients are actually capable of maintaining a consistently low level of performance across multiple measures assessing the same skill. Is there research on the extent to which clients are able to maintain steady performance while persistently exerting less than peak effort?
There is not good research on that specific issue. The problem we have with that, and in figuring out how to deal with those issues, is that even though the latent construct may be the same, if we're giving multiple tests, the specific tasks may not be the same. And there may be splinter skills that come into a person's performance, or simply domain sampling errors across different measures of the same latent construct that cause a person to do better on one versus another, or do worse on one versus another. And figuring that out is very difficult. So we just don't know much about those kinds of base rates. And base rate data on tests of a common construct are really important if you're going to determine whether or not someone is consistently performing in a way that might represent something like dissimulation or lack of effort, or for some other reason. We do have some base rate data on how often, for example, IQ fluctuates across the major intelligence batteries. And we know that, for example, the average difference, if you were to give 2 or more major intelligence tests, which we typically don't do to the same person, we know the average score difference in the population is about 9 points. And those 9 points are associated with primarily errors of domain sampling. But for example, if you were looking at giving 2, 3, 4, 5 measures of visual spatial skill, those are not going to have identical stimuli, and you don't have base rate data for the fluctuations in that reflect the differences associated with errors of domain sampling. So you really need to use things that are co-normed. And PVTs like the PdPVTS, which does have 5 co-normed tasks and have base rates for every possible pattern of pass-fail to give you that indication. So it's very difficult to engage in that kind of analysis without really detailed base rate data. And about the only place we have that is in the comparison of a person's performance across multiple major IQ tests.
Thank you so much for explaining this, Dr. Reynolds. We have a couple of more questions. The next one is, how does adding a PdPVTs impact standardization and score interpretation, since the addition of these validity tasks will change the standardized administration?
I don't think they changed the standardized administration at all. You don't give them in the middle of another test. For example, if you're giving the test of memory and learning, you wouldn't give the first 2 subtests and then throw in a performance validity test. You give them in between other tests that you're giving. So if, for example, if you were to give a RIAS 2, at the conclusion of that, you might give one of the PdPVTs tasks, and then you might give one of your achievement tests. And at the end of that achievement test, give another of the PdPVTs tasks and see. And that's no different than what we do now. There is no standardized order. In fact, there's not even a standardized comprehensive battery of tests. Not everybody gives the same intelligence test and the same achievement test and the same measure of memory and the same CPT and all of those things as part of their battery, and always in the same sequence. So that's not how tests are standardized. So it's not a disruption. It doesn't change the standardized administration of any of the tests. at all, any more than giving your measure of academic achievement first in your battery and giving your intelligence test second is a change in standardized procedure. So we all have our own ways of putting together our comprehensive battery when we do an assessment. And frankly, for all children, we probably shouldn't even use our own comprehensive battery with a particular child in exactly the same order with every child because of needs for developing rapport and because of the history. In my own practice, often once I've read the referral question and have some history, I formulate a battery that answers those questions that I think is best for answering them with this particular child. But then during the actual assessment process, as I see how the child is performing and see patterns develop, I may completely change my mind about what test I'm going to give next. Now, I don't do that in the middle of a specific test, but at the end of the test, I may change my mind completely about other tests that I need to give to properly address the referral question based on how the child is responding to the testing I've done so far. So does that violate any kind of standardized procedure? No, not at all. In fact, we have to have that kind of flexibility. So inserting PVTs into your battery between tests, not within another test, in no way upsets that kind of standardized procedure.
Yes, absolutely. The next one is if you have, it's a situation, Dr. Reynolds, if you have a high schooler from an affluent private school who does not um, do well on PdPVTS and you suspect is faking to get extended time on SAT or ACT, what would you do? Would you stop testing and let the parents know? What if parents have coached the students to fake?
Well, it's really kind of two different questions. One, whenever I have someone who fails a PVT, the first thing I do is ask myself why. Is it a lack of effort on their part that's related to my level of rapport with them and my degree of engagement with them? Is it because they're bored and just not giving me their best effort because of that they're not engaged? Or in fact, are they attempting to dissimulate? And I try to address that question internally. And then if I decide and realize that, hey, I've been testing for a while and I got bored with this because we've all given the same test many, many, many times. And I try to re-engage with them. And if that doesn't work, and I decide, they're just really not trying. And perhaps they're here because they want accommodations on their SAT or ACT, then I need to talk to them about that and tell them that, hey, go back and say, I can tell from the way you're responding to some of these tests that you're not really doing the very, very best that you can do. And I can't reach accurate conclusions about your future needs or any accommodations for testing or anything else about your learning and how to be of assistance to you and your family unless you absolutely do the best that you can do. So I try to encourage them and engage with them and be sure that they get the best effort. If they were to continue to fail a PVT after that, then I would conclude at the end of the exam that they did not give sufficient effort to allow me to make the typical interpretations that are required in order to draw conclusions about the need for any accommodations. And sure, parents are going to be unhappy about that, but I don't have control over that, just like I don't have control over their actual level of skill and performance. The exam goes the way the exam goes. And I do my very best to elicit maximum performance. That's part of our job as examiners, is do the best that we can do to elicit maximum performance. And unless a child or adolescent were to tell me they had been coached, I would not accuse a parent of coaching. I would simply note in writing a report about the exam that I did not get best effort and was unable to obtain that even after reviewing the child's performance when they failed performance validity testing, that their level of effort did not sufficiently improve. And therefore, I'm unable to reach conclusions. I've had that happen in exams. I've had it happen in disability exams. I had it happen in a major lawsuit against Walmart with a physician who was claiming a brain injury due to a fall in a Walmart. And what I wrote in my report was that she didn't give adequate effort and therefore did not cooperate with the instructions in the exam, even though I tried to re-engage with her. And that was the way it was, and I had the data to support that because I had used objective performance validity tests, and I wasn't just flying by the seat of my pants and saying, well, it really didn't look like she was giving good effort. I had objective documentation of that. But I think it is important to use that information and use PVT failure initially to engage with the examinee in a better way and let them know that you know, and not in an accusatory way, but in an encouraging way, and let them know that in order to be of assistance to them and their family, that it is on them to do the very, very best that they can do.
Thank you so much, Dr. Reynolds, for the informative presentation today and answering all the questions. I mean, we could not cover all the questions. There are such great questions, a lot more. I will be emailing some of them to you. And I would like to thank to all our attendees who joined. If we did not get to your questions on this webinar, please send us an email at marketing@mhs.com, and we will forward your questions along to Dr. Reynolds. On this note, we are at the end of our webinar, and I wish all of you a very nice rest of your day. Again, thank you so much, Dr. Reynolds, for joining us today.
Well, and thank you again, everybody, for being here and being willing to listen to me. And I appreciate the good questions. I like good questions like those, and they all work. So thank you again for being here.
Of course. Thank you.
Bye-bye.